Good evening, everybody. Thank you for joining us here early today. Good evening to all professors, doctors, optometrists, industry partners, colleagues, and the organizing team who have gathered here today for our CME webinar, jointly organized by Singapore National Eye Centre, Cordlife Group Limited, and OptiQ. My name is Angela, and I'm your host for today. I welcome you all and thank you for taking your precious time to join us for this educational online session. We are so honored to be at the forefront of knowledge, innovation, and technology, and are extremely excited to be sharing this latest groundbreaking technology in the ophthalmology field with you. Today, it is with great pleasure to have Professor Jodhbir Mehta here with us. He is the head and senior consultant at the Corneal and External Eye Disease Department at SNEC, and he will be sharing on how extracted corneal lenticules from smile surgery can potentially treat presbyopia and other ocular conditions in the future. Professor Jod will also be discussing the lenticule implantation procedure. We also have Dr. Tang Kin Fai, Laboratory Director of Cordlife Group Limited, here with us today to share on the technology behind processing and cryopreservation of the precious corneal lenticules for future applications. Before we start, please let me walk you through some house guidelines to ensure the most comfortable and conducive webinar environment for all of you. You may key in your questions in the chat box at any time at the bottom of your Zoom screen. Questions will be addressed during the Q&A segment at the end of the webinar. Questions of the same nature will be answered together, and we appreciate your kind understanding that we may not be able to complete all questions due to time constraint. Without further ado, let's welcome our first esteemed speaker to share with us on the potential applications of corneal lenticules. Prof. Jod, please.
Thank you, Angela. So I'm just going to share my screen. Okay, so we can see my screen, yeah? Okay, great. Okay, so good afternoon, everyone. So welcome to this webinar. So I'm going to talk just a little bit about some basics, first of all, so to give you an idea. And then as you go through the talks, we'll make it a little bit more interesting about where we can basically use these lenticles for itself. So the first thing to really answer is basically what is a corneal lenticule? So this is actually quite simple. These are my financial disclosures. They pertain to some of the technology to do the lenticle creation. So, of course, a corneal lenticule is a piece of corneal tissue, and this can be of various size and various thickness. So when I mean size, I'm talking about diameter. The thickness of the lenticule can be pre-programmed by the laser. And really, the whole technology behind corneal lenticule work has really come as a byproduct of a refractive surgical procedure that we called initially RELEX, or refractive lenticle extraction. Refractive lenticle extraction was a procedure that was developed by Carl Zeiss Meditech in Germany. The first RELEX procedure was performed in 2008. And at the beginning, there were two distinct RELEX procedures. One is what we call flex, which you can see in the top right-hand corner over here. And this was similar to basically like a LASIK flap, but you can see what we did over here is we peeled the lenticule from the surface of the cornea, but there was a full flap procedure itself. But the more interesting procedure came a few years later, and is the procedure of choice that everybody does now, is what we call basically SMILE, where instead of having a full flap over here like LASIK, we can take the lenticule out through basically a small incision. And of course, we know that this has huge advantages to the patient by having a smaller wound size over here, as opposed to the full flap like we see in LASIK. So one of the questions is really, how can the laser actually cut a lenticule? Now, we know femtosecond lasers are quite clever. They work in a technology where you have basically cavitation bubbles being formed in the corneal surface. On the right-hand side over here, you can see a histology section of a cornea. And what you can see is that where we basically fired the laser, as the cavitation bubbles expand, and they're basically next to each other, you'll get a resection plane. So that you can understand how this works. And in the diagram on the left, what some of the parameters that we adjust with the laser is what we call spot and line spacing. And you can think of this basically in a two-dimensional structure itself. But in order to cut a lenticule, not only do you have to be accurate in 2 dimensions, so in the horizontal X and Y, but you need to be accurate in basically 3 dimensions. So you need to be X, Y, Z. And in order to be able to do this, this is only possible with certain laser systems. If you look at the current laser systems available on the market to actually make flaps, you will see these four popular femtosecond laser systems. The differences obviously between the laser systems you can see in the energy or the repetition rate of the laser. And this equates the amount of energy that goes into the cornea in order to create the flap. What you can see is that some lasers are working in the low kilohertz range. So when I mean low kilohertz, I'm talking about 150 kilohertz to maybe 160 kilohertz range. So what that tells you is that the energy in order to create a flap is actually slightly higher. So it's what we call a high energy laser. So it uses a cavitation bubble to make the plane that you will then lift up as a LASIK flap. If you look at the other lasers, you can see that suddenly this jumps to 500 kilohertz for the VisuMax and megahertz for the Zima lasers. So these work in a much more lower energy range system. And we know from studies that we've conducted and other people have conducted as well, that you need to be able to have a low energy laser system in order to be accurate in the Z-axis and be able to cut a lenticule. You're never going to be able to cut a lenticule with a high energy system because the cavitation bubbles will be too large and you will not get accuracy in the Z-axis. So that's why it's possible to cut a lenticule with these lower energy systems, because it's like basically using a laser to actually etch the shape into the cornea itself. So if we want to get a lenticule, there's basically two ways of actually achieving this. One, of course, is from the patient who's undergoing a refractive procedure such as SMILE, and the second is from the donor cornea. What you then need to have is a femtosecond laser. And on the top, you can see one of my patients having SMILE, and on the bottom, you can see one of the donor corneas that we mounted an artificial anterior chamber maintainer, and we're basically going to get a lenticule from the eye itself. When we're doing a SMILE procedure, as many of you will know, the thickness of the lenticule will depend on the refractive index of the patient. So if we basically want to do refractive error of the patient, so if you want to do a high dioptric correction, say a -6 or -8 procedure itself, then the lenticule is going to be thicker. If you're going to do a low dioptric treatment, say it's such a -3 treatment, then of course the lenticule is going to be thinner. It's only going to basically be maybe about 30 microns. The diameter of the lenticule we set depending on the optical zone size that we basically pre-select in the programming. And you can see below here where I've taken out the donor lenticule from this donor cadaver tissue lying on the surface, and on the bottom, you can see exactly the same thing happening. Of course, the lenticule shape can vary depending on what kind of refractive error we're trying to treat. If we're going to do a myopic treatment, which of course is the most common refractive surgical treatment, you'll see the lenticles that we extract from the eye, from you can see in the histology picture above over here, are thicker in the central area and thinner on the peripheral side. Typically, we keep the peripheral edge normally about 15 to 18 microns. Sometimes we increase it when we do low dioptric treatments. For hyperopic treatments, of course, it is the opposite. So in hyperopic treatments, what you will see is that lenticles will be thicker in the mid-periphery and the peripheral area, and they will be thinner in the central area. So there is a different shape ability, and this is just all programmable on the software on the laser system. If you take the lenticule and you basically section it and you scan it with a scanning electron microscope, like you can see in the pictures over here itself, and you go from the anterior surface into the middle of the stroma and then to the posterior surface, what you can see on the video screening over here, you can see red cells, and there's a lot of blue cells, and then you can see basically red cells. Now, the red cells are staining up with tunnels, so they're basically dead cells. The blue cells, they're live cells, and the ones at the back are also basically dead cells. So what this tells you is that the laser is so accurate that it actually only kills the cells in the peripheral part of the lenticule. So it doesn't damage the cells in the middle part of the lenticule. If you take the lenticule out and you stick it in a culture dish, what's going to grow from it? Well, of course, we all know that in the corneal stroma, it's primarily made up of keratocytes, and in the right culture medium, you'll get these cells basically growing out from the surface. What happens if you freeze the lenticule down? Well, if you freeze the lenticule and you then basically take it out and you thaw it out and you culture it again, of course, you can still grow keratocytes from the culture medium. Now, the keratocyte number will go down due to the thawing process, but it's still possible to culture the keratocytes. And you can just see from over here, or we did some PCR analysis, you can see the marker expressions, keratoconus and 3A1 are high, which show basically high levels of the mRNA that we basically see in cells that are from the corneal stroma. If you take that lenticule and you look at it under transmission electron microscopy and you look at the architecture of the lenticule, you will see this typical pattern that we're all basically familiar with. And we all know that the collagen fibrils in the cornea undergo destructive interference, and that's what allows us to see clearly into the distance itself. Importantly, though, if you freeze the lenticule down and you take it back out, you thaw it out, and you undergo the same examination, you can see that the lenticule maintains the same architecture. And this is really important because if we're going to think about using this lenticule for some of the applications that we'll be talking about later, it is important that you maintain the interference pattern of the collagen fibers. If you lose the interference pattern, then what happens is the visual, if you put that back into a patient, then of course the vision will basically be blurred. And the maintenance of the interference pattern is very important. And you can see that from the study over here, where we looked at the mean number of collagen fibrils and also the fibril density in order to basically show that the fibrillar maintenance pattern of the interference was basically maintained. Now, there is a slight difference in the density, of course, when it's basically frozen versus fresh, and that's normally because of water or fluid coming into the lenticule during that time period. On the pictures below, you'll see the histology section showing a cross-section through a lenticle, just saying what I basically told you on the video, where you see the dead cells on the anterior and the posterior part, but in the meat of the lenticle, the cells are basically all alive in the central part. Okay. Now, people often say when there's a new technology, and we've been doing lenticle extraction back since 2011 now, so over 10 years. But back in 2008, 2009, this was a very, very new procedure itself. And obviously, LASIK is the most dominant refractive procedure that was being performed around the world. But more recently, the number of cases of SMILE or lenticle extraction have been increasing throughout the world itself. And in fact, what's happened is that now over the last few years, other companies now have gone into this technology to do lenticle extraction procedures. So certainly this is a procedure that's here now. It's already, the results in literature have shown it to be as good as doing standard LASIK, if not better in some respects. And I think it will keep on improving into the future as more and more competition now comes onto the market. We see newer machines, like some of these you can see in this picture over here, that can do even more complicated things than even that we were available to do when we started doing a lenticle extraction. And I think with these newer technologies, all of these machines are all basically producing lenticule extraction techniques for you to basically remove your corneal lenticule from the cornea itself. So if you get the lenticule itself, of course, there's lots of things you can imagine that you can basically do with it. And of course, we've never had access to corneal tissue like this ever before because the LASIK will basically vaporize the tissue. We could, of course, can think about using it for autogenic use, but it would be nice to use it in allogenic use as well. So there's ways that you can actually remove all the cells completely to just make it a pure scaffold. We can alter the refractive power of the lenticule itself. So you can imagine this is just using an excimer laser, some of the work we did in SERI, where we're able to thin out the lenticle very precisely using an excimer laser. So we can alter the shape of the lenticule that we basically want to think about using it for other applications as well. And of course, if we're looking in ectatic diseases, you can simply cross-link the lenticule before we basically put it back inside the cornea. This can be used for keratoconus or even secondary ectasia to previous LASIK. And there's a protocol here that we published previously on how to basically do this. So in summary, for the first part, lenticle extraction is becoming an increasing popular procedure. There's over 3.5 million lenticle extraction procedures already performed worldwide. And we see this only as a growth market. As more and more companies now are making lasers that can do lenticle extraction, we will see this number really going up a lot. Most of the other procedures are companies that are doing lenticle extraction are still a little bit in their infancy. Two are basically CE marked, like I showed on the previous picture, the Zima and also the Smart Sight by Schwind. This has allowed us a unique source of human stromal tissue, which we've never had in the past itself. And of course, this was previously only possible if we used basically cadaver tissue. So the potential for this use of tissue is tremendous. And ideally, we can think of lots of applications, which I'm going to show you some examples of in the next couple of slides of where we can actually use this tissue. Okay, thank you. So the second bit I'm going to talk about now is potential applications of corneal implantation, because I've shown you basically how we can get the corneal lenticule. You know what's basically in the lenticule. So what can we basically do with this lenticule tissue? So as I mentioned, the different shapes that can basically be cut depending on the patient's undergoing a myopic correction or hyperopic correction. So currently, I put a list over here of indications for use. So some of these have already been published in the literature. There are already some trials in some countries around the world where it is already basically being used. So it's typically can be used for tectonic purposes, such as perforation, gluing perforations. Trying to get emergency corneal tissue can be difficult for a lot of centers. And certainly, if you have access to a lenticule, you can emergency basically seal up a corneal perforation in the acute phase and then come back and think about doing a more conventional graft once you get the availability of corneal tissue. For therapeutic uses, of course, it can be used for keratoconus, and I'll show you some examples in a bit more detail, and also for secondary corneal ectasia, typically following LASIK surgery. Some people have used it basically for stromal expansion in patients who are keratoconic, who need to undergo cross-linking. You can basically put the corneal stroma, a lenticule on top of the corneal surface after you remove the epithelium, apply some basically riboflavin to the whole thing so it's soaked through, and then apply the UV light. And by having a little bit of extra tissue there itself, it will bulk up the cornea and you get the effect on the underlying corneal stroma without actually putting the endothelium at risk as well. From a refractive perspective, of course, implanting a myopic lenticule into a patient that's hyperopic or even aphakic can help correct the refractive error, and we'll show you some uses from there as well. It can potentially be used as a treatment for presbyopic inlay. So this is one of the studies that we've been doing in Singapore as well. And I'll show you how we customize the lens for that. And something very new is that we have a project ongoing at the moment where we're using this as a drug delivery system. So I'll just show you one slide from that because a lot of that data still hasn't been published. And obviously it can be used as a tissue engineered scaffold because now you have a pure source of human stromal tissue, which of course would have been very expensive if you get it from a recombinant source. And now this is something that's typically disposed of when we're doing this lenticule extraction or SMILE procedure. So lenticule implantation or keratophakia is actually not a new concept. So Barakay actually was one of the first people who basically coined this term of keratophakia. And what he described was a very complicated technique where they got a lenticule that was actually cryo-laid into a convex lens. So he got a lenticule from the stroma and then using a lathe, this was basically then altered into a shape. This was then placed onto the stromal bed and then the cornea basically applied onto the surface. And you can see from the picture over here, it was like applying a myopic lenticule into the cornea, and then this made the cornea slightly steeper in the center itself. So this would be like correcting a hyperopic correction itself. And the idea of this stromal keratophakia, as he coined it, was to treat hyperopia or aphakia. The issue with this technique, of course, this is a technique that was done basically in the 50s and 60s, is that it was very, very difficult to do. Okay, so you can imagine at that time, there were very few publications basically on outcomes. The Barakay paper is the second one over here itself, and you can see they did about 41 patients. So technically, it was very challenging to cryo lay that lenticule into the shape that you want and to do it precisely as well. So you can see these were real challenges. And most of these papers are published between 1981 and up to basically 1983. And because of the difficulty with this, it wasn't a widely taken up technique. However, if you do look at some of the results, the results are actually quite interesting because a lot of patients did actually get improvement in their visual acuity. The problem with the technique was it was a complication actually creating the lenticule and doing it in a predictable, reproducible manner. Because what happens is if the shape of the lenticule is not being done correctly, you will induce irregular astigmatism. Cutting or using a microkeratome, you've got to bear in mind this is in the 70s, so this kind of technology was very expensive. The equipment itself back in the 70s was $100,000. So you can imagine if you increase the monetary terms up to now, how much that would basically be. That'll be almost $1 million. So of course, hardly anybody was able to afford the equipment to basically do this. The visual recovery was often poor because after the cryolating process, so this is the importance of having a good technique for your cryopreservation. The stroma was typically hazy and then swollen. And of course, this can basically lead to interface scarring. So it's important, whatever process you do with the cryopreservation, it tries to maintain the integrity of the cornea itself. And this was an issue because obviously the cryopreservation technique that was used in these studies, there's a lot of cellular necrosis and a derangement of the collagen structure. So maintaining that nice collagen interference pattern is a key to basically this whole problem. So many of these limitations have been solved, to be frank, because we have a femtosecond laser. And that's why this technology has really been renewed now. So back in basically 2010, when we first started doing a lenticule extraction in Singapore, we had this idea of thinking whether we can actually reverse the procedure itself. So what we did is that I cut lenticles from these rabbits. And then 1 month later, you can see they had a flex procedure. So there's a flap all the way back. We basically cryopreserved the lenticles on our RGP contact lens. It was kept in this basically contact lens case. So 1 month later, I went back, we lifted up the flaps, and then you can see what I'm doing over here is I'm taking the lenticule off the RGP contact lens and then putting it onto the stromal bed. And then I'm basically putting the flap basically back down to finish the surgical technique itself. So we normally did this at 1 month because we wanted to see where proof of principle to see if this could actually work. So what you can see from the figure over here is that you can see that obviously using the anterior segment OCT, you can see after 14 days after implantation, you can see the lenticule in the stromal bed, and this obviously thins out basically by 28 days. So, and you can see that we're able to reverse the stromal volume of the rabbit cornea. So we did the stromal volume went back to what it was. So you didn't actually lose anything in the stromal architecture of the lenticule after we basically put it back inside to the rabbit itself. More importantly, however, you can see from the pictures over here, if you look at the clarity and measure the haze using the grading scale, you can see initially after the implantation, there was a little haze up to about 14 days. The rabbits were given antibiotics and steroids, and you can see this dramatically reduced down by 28 days. And in fact, by 28 days, it was same as the control group. So actually, you didn't get long-term haze. And we know from lots of studies that rabbits typically get a lot more haze than humans. And you can see from over here for the first time, we're able to reverse the corneal refractive procedure back to basically what it was before. Okay, so the thickness obviously will be slightly thicker because there's still a flap there, but essentially the clarity of the cornea was basically reversed by looking at this lenticle implantation. And this was obviously the study was done in rabbits. When you sacrifice the rabbits at 28 days and you look at the histology, you can see from here on in vivo confocal microscopy that there was a little bit of haze at 3 days. This was reduced by 14 days, and by 28 days, the keratocyte activity at the anterior and the posterior part of the lenticule went back down to normal. And this is shown in this bar chart in the bottom left over here. At 28 days, if you sacrifice the rabbit and then you look at the corneas in detail, one of the things that we wanted to look at whether there was actually any myofibroblasts or haze forming cells. And you can see from the histology over here, there's no haze forming cells around the lenticule. So not only did the lenticule go back inside the eye and we maintain corneal clarity visually that we're able to see with our grading system, but actually even from a histological viewpoint, there was actually no haze-inducing cells at the anterior or the posterior margin of the lenticle itself, which is really important, of course, if we're going to think about clinical applications. If you look to see whether there's any fibroblasts, you can see there was just one fibroblast positive cell over here. So it shows you there is some repair fibroblast cells around the lenticule, but there's no haze basically forming cells, which is important. If you look and stain around the lenticule and we're looking at extracellular matrix formation, you will see there is new cellular matrix laid down by the keratocytes around the lenticule after it's basically implanted. And you can see that by the green line over here, and L shows you where the position of the lenticle is inside the eye. So once we're able to show that actually this technique does work and we're able to maintain corneal clarity, the next thing we wanted to do is to see actually how accurate is this from a refractive standpoint, because if we wanted to reverse the myopia, we wanted to see, can we actually get this done quite accurately? So of course you cannot use rabbits for this situation because rabbits have very steep corneas. So in this situation, we actually went to NHPs, we went to basically monkeys. So on the OCT pictures over here, you can see the virgin cornea before relax. At 16 weeks, you can see after we did relax, I did a -6 treatment on these monkeys. At 8 weeks, this is after implantation. So you can see on the OCT, the lenticule inside underneath the flap after implantation, and you can see the lenticule thinning out basically by 16 weeks after implantation. If you look at the keratometry, you can see that basically it was 58, so still reasonably steep cornea. These were young monkeys. And of course, when we did a basically -6 treatment, it dropped down to 54. So of course, the cornea comes down. After I basically implanted the lenticule, it went back up to almost 58, and then it basically settled on at 58 as the swelling basically settled down. So there is a difference of 0.5 of a diopter between this after reimplantation and the virgin one, because of course there is a flap created. This wasn't done through a small incision, this was done through a flap. If you look at the refractive change, what you can see is the monkeys were myopic as well, so they're -1.64. Obviously, they became hyperopic after I did the treatment. And you can see that once they basically settled down to 16 weeks, 4 months, you can see that their myopia basically was returned back down to almost exactly what it was before we actually did the surgery. So what this showed is that not only could we actually maintain the clarity, there was no haze formation from a histological standpoint, we increased the stromal restoration as we showed in the rabbits, but it was also accurate from a refractive point of view. And once you can show something is accurate from a refractive point of view, of course, it gives you multiple options with respect to some sort of treatment options. So this was the timeline from when we first published our paper. So we published our paper back in 2012, 2013. And then following that, after we presented at some meetings, Dan Reinstein in London did the first case of a human stromal lenticle implantation in a patient in Nepal. So this was an aphakic patient that he implanted the lenticule in. So this is almost like 7, 8 years ago where he did the first basically patient as well. Subsequently to that, in India, they started doing some cases. So these are patients who are hyperopic. This is from Sri Ganesh's group in Bangalore. And he did 9 patients who are basically all hyperopic. You can see basically that vary from +3. Patient I number 5 is obviously an aphakic. It's +11 over here itself. And you can see that after he did basically the lenticle implantation, which you can see on the OCT over here, this is the lenticle that was basically implanted. You can see the improvement in the visual acuity, and the visual acuity basically improved all the way post-operatively. The best way to see visual acuity varied from almost 20/20, which were almost in about 4 or 5 of the eyes, 20/30, 20/40, all the way up to basically about 20/60. So you got pretty good improvement in the refractive error. And this was just taking, not even customized SMILE lenticules. They were taken from a donor. They were basically taken from a patient. They were cryopreserved, and then they were implanted basically back into the eye. You can see the spherical equivalence of the implanted donor. So they tried to match the spherical equivalent of the implanted lenticule to the patient as close as they can get. But you can see there are some discrepancies, like with number 4, the spherical equivalent was basically 7, and while the lenticle that was implanted was only 6.8, number 5 was 12.75, while the lenticle that was implanted was basically 10. So there were some discrepancies from this, but these were taken from patients. These were also cryopreserved, but this was just done in the institute in India, and then they basically defrosted them out and then basically implanted them to the eye. So this showed that what we were able to show in rabbits and in monkeys was then actually reproducible in basically clinical patients. On the topography over here, you can see this is pre-op. This is day 1. You can see a little bit of regularity on the surface, and the regularity basically becomes stable at 1 month, and it's pretty stable at 6 months. And what you can see is the flat shape of the central part of the cornea basically becomes more red. So it's basically becoming steeper. And this is typical, basically changing a hyperopic eye into a little bit of a myopic shift to basically to control the refractive error. So the other refractive option is basically using this as a presbyopic inlay. So we were working in this area as well. This is an example of one of the monkeys that actually underwent lenticle implantation. So you can see I've confined the lenticule down so you can confine it to a smaller shape. So typically we confine it to about 1.5 to 2 millimeters. And this is implanted using a pocket that's created with the femtosecond laser into the middle of the cornea. And gently using a bimanual technique, you can tap on the surface, and then you can adjust it into basically position itself. So this is one of the monkeys. If you look very closely over here, you can just see where the reflection is on the first Purkinje. You can just see the image over here of the lenticule, and you can see the increase in elevation on the anterior axial map. And likewise on the OCT, you can see the implantation of the lenticle itself. And what we found was in the monkey studies that we basically did is that we got an increase in steepening of about 2 to 2.5 diopters, which ironically is very similar to what was achievable with the range drop. But the big advantage of this is collagenous tissue. So it's completely biocompatible with the cornea itself. You do get an effective zone situation where you get a zone around the area of the lenticle implantation, which is normally 1.5 to 1.8 times the physical dimensions of the lenticule. So what that means is if you basically implant a lenticule of 1 millimeter, for example, you'll get a zone almost about 1.8 millimeters around the lenticule. So what it means is that not only will the patient be able to see near, but the patient will also be able to see intermediate vision as well, because they can use that zone around the area. So at the same time, when we were finishing our studies in monkeys, Susan Jacob in India basically did some patients. This is from her paper. And you can see on the top right-hand side over here, that these are the patients that she basically did. So this is between the age range of 43 and 41 and up to basically 45. Typically, what we were basically using for the thickness of the lens, we use it basically about a -3 treatment because we know there's going to be some swelling, a deswelling of the lenticle when we implant it inside the eye, which is approximately about 50 microns or 50 to 60 microns of tissue. So she used lenticles varying between 61 and 58, sorry, to 66 microns in thickness. But again, she used just other patients' lenticules, so clinical lenticules, while we were doing something slightly different where we're taking from a donor cornea. If you look at the near visual acuity, you can see the best vision was in the patient 4, which was J5, but you can see the post-op uncorrected near visual acuity improved to J2 in every single patient, okay, which is quite impressive. But also, as I mentioned, because you get this effective zone around the central part of the lenticule, you will also get an improvement in intermediate vision as well. And that's exactly basically what she found in some patients. The key thing is because the lenticule that you basically put in is so small, you shouldn't get any effective loss of unaided distance visual acuity. So that's why this is superior to doing blended vision or monovision, where you may get some degradation of your far vision in that eye itself. And if you're looking at the reading speed in the eye that has the lenticule, and you compare this to the fellow eye, you can see there's an improvement in the reading speed in everyone that had the lenticle versus basically the fellow eye. So this showed that you could basically have a lenticule, make it smaller and implant it, and it shows a proof of concept of using this for presbyopia. Okay, so the fourth indication was basically using this for keratoconus, and I'll show you some of the work that we do in collaboration with a group in Italy. So when you look at keratoconus, there are basically two major concepts of basically putting lenticle implantation inside the eye. One is basically putting a planar lenticule, and this has been done by Jorge Alio's group in Spain, where underneath a pocket, he'll implant a very flat shaped lenticle. So this is a uniplanar lenticule. The thickness is actually quite flat on the surface, okay? The other option is basically using a hyperopic lenticle. So this is some of the work that we've been doing in collaboration with Mario Nubli and Professor Mastrapasca in Chieti in Italy. And what you can see on the OCT is a patient with keratoconus, and the one below over here, you can see the hyperopic lenticle that we've implanted inside the cornea over here itself. And you can see the concept is that we're basically making the thinner area of the cornea thicker, and we basically want to make the thicker central area flatter. Okay, so I'll show you again on these images. So this is the overall concept. So this is your typical scan of a keratoconic patient. So you can see that typical steep posterior float or even anterior float. And what we want to do is that by implanting a lenticule, this goes back to Barraquer's law, when we implant a lenticule into the middle of the stroma, we're increasing the stromal volume. And what we're doing is we're flattening the central area. So we're turning it from purple to basically red, and we're thickening out the peripheral area itself. So we're changing that from a very crimson color to a light blue color itself. So we're elevating the surface. This is showing it. So before we started this project, we initially tested this out on a model, a keratoconic model. Now, there's no animal model to basically use a keratoconus. So this was basically done using an eye bank itself. So what we did is that we thinned out the back of the cornea of a cornea using an excimer laser to try to induce ectasia. And you can see from over here, we're implanting a lenticle diameter of 6 millimeters or an 8 dioptric power. So this is basically before. And you can see that after we implant the lenticle through a pocket, you can see the central part of the cornea is basically flattened and the peripheral area has basically bulked out. So it's got basically thicker. So I'll show you again one more time. So this is basically before, and this is basically after we've done the lenticle implantation. So this is basically just a proof of concept, showing you the same thing again. This is showing you in the model. This is pre, and this is basically post. So you can see this red ring around the area. So this shows you where the lenticle has been implanted and where the cornea has got thicker. And you can see the central area where it's green on the left-hand side. So it's pre-op, so it's slightly steeper. And after we implant the lenticle, it becomes flatter, so it becomes bluer. So that's become flatter, and the mid-periphery has basically become thicker as well. So this shows you as a proof of concept that this could actually basically work. And this was published back in 2016. So again, we look at basically before, and this is basically afterwards. So you can see a flattening down of the steep area in the central area where it's basically red. And you can see this area around the periphery over here where it's green, where it's blue on the left-hand side, so it's flat, and it becomes green on the right-hand side where it's become thicker as well. Okay, so it was basically proved without a doubt that this concept of biomechanically changing the stress in the cornea by implanting a lenticule should be basically feasible. So we embarked on a clinical study. This is basically the first 10 cases of advanced keratoconus. You can see the range of the K readings is quite high, between 55 to 70. So most of us will probably do basically DOLC in the situation. The corneal thickness was basically 290 to 450. And in fact, these patients were actually listed to basically have DOLC done, and then basically they were offered this as an alternative. The cornea has to be transparent because, of course, you've got to create the pocket with a femtosecond laser. You can see the visual acuity was quite poor, and these patients were typically contact lens intolerant. Like I said, these are typical patients that we normally do basically a DOLC. The lenticules for this study were obtained from an eye bank, which is different to what I showed you from Susan's study in India and Sri Ganesh's study, which were taken from patients. This was taken from a donor corneal lenticule, as I showed you in the video basically earlier itself. So we use the femtosecond laser to create basically the lenticules, and then we'll talk about the implantation on the next section. But you can see that in lenticle implantation is basically over here, and exactly as I showed you in the model, thicker in the periphery and thinner basically in the center. So this is the hyperopic lenticule. This is what the patient looked before. This is what the patient looked basically 1 week afterwards. And the really key thing is that this surgery is actually pretty simple to do. And you'll see that on the implantation. And it's a lot less complicated than doing a complicated DOLC procedure, as many of you will know. Using retroillumination, you can see over here, this is basically the lenticle that's basically been implanted inside the eye. You can see that nice shadow effect and the thickening in the peripheral area and the thinning in the central area as well. These are some of the results. You can see the preoperative corrected visual acuity in red. Then obviously these are quite poor because these patients were also contact lens intolerant, so they're unable to wear glasses. And you can see the post-operative corrected visual acuity in blue. And you can see significant improvements in all of these values with respect to patients seen in 2050, 2063, and 2080. So this is basically improvement in their vision so they can actually wear glasses, as opposed to having to wear, none of them could wear contact lenses if they were intolerant of contact lenses. So they're actually now to be able to go to having glasses and avoid having a complicated transplant procedure. Of course, you can see the changes in pachymetry. So as most of you will know, most patients with keratoconus have a thin area, normally in the inferior part of the cone. And you can see post-operatively, this is centralized to the central area. So by thickening out the paracentral area of the cornea, we've now shifted the thickness to basically the central area, and you can see the improvement in the mean spherical equivalent going from -7 all the way to basically -3, and it's stabilized up to the 6-month follow-up of the study at about a level of about -3.5. Last thing I'm going to just show you, this is something quite new that we've been working on for the last probably 6 to 8 months in collaboration with Dompe and Mario's group in Chieti, is where we're looking at using the lenticules as a scaffold for drug delivery. So you can see from over here, these are fluorescent nanoparticles that have been impregnated into lenticules that have been decellularized using a technique that we previously basically published. And then following this, this could then be applied to the surface of a cornea to give you basically a release profile of the drug over maybe 28 days or maybe even basically 1 to 2 months, as for long as you basically need the lenticule itself. And this is a very new, exciting area that we've basically been working on. So in summary, lenticular implantation can be used in many areas: tectonic reasons, therapeutic, refractive, and also basically a scaffold. The chance or the ability to use a fresh lenticule actually is pretty small. Hence, cryopreservation will be the key here, because the chance of actually getting a patient who happens to be basically -3 on the same day, you have a hyperopia patient who happens to be +3 to then basically implant into his eye is basically 0. So what will have to be that the lenticle will have to be preserved somehow in some way, so that you can then call up on the lenticle to basically then get it back for the individual to then basically put it inside the eye. Of course, if you're going to use it for presbyopia, then if you have your refractive surgery when you're 24, 25, you're not going to probably need that lenticle until you're basically in your 40s. So the lenticle has to be stored for at least 16 years. Customization with excimer laser and cross-linking is basically possible, as I've basically shown you, and I think it's quite interesting approach to really customizing even a little bit more detail, especially when we're using it for keratoconus, where we can actually even alter the shape, or even in the future, maybe do topography-guided etching of the lenticule from the donor cornea itself. Access and storage of lenticules will increase their availability for use. So this is going to basically happen if there's a storage facility that can store the lenticules. Then of course more and more corneal surgeons will basically use lenticules itself. And currently we have approval for lenticle implantation for Singapore for autogenic use, and Kai Fang will talk about this in a little bit more detail, but obviously not for allogenic use at the moment, but for autogenic, so it can go back basically into the same patient. Okay. So the last thing I'm going to basically talk about is lenticule implantation, the actual technique itself. I'm just going to play this video first of all to give you an idea, and then we'll talk about this in a little bit more detail.
The first step in the lenticule implantation procedure is the creation of a pocket. This can be done with many commercially available femtosecond lasers. The pocket is typically positioned at approximately 100 microns away from the epithelial surface. Once the pocket has been created, the cavitation bubbles and adhesions can be removed using a simple spatula inside the pocket. The lenticule is then created using a femtosecond laser, and following which it is trephined to 1 to 2 millimeters and then stained with some fluorescein dye. It is then carefully picked up with a pair of forceps and inserted into the previously created pocket incision. The lenticule is placed so it is over the center of the pupil, and this can be adjusted using a bimanual technique with a spatula on the anterior surface, keeping the lenticule in position.
Okay, so the video is showing you a technique for presbyopic inlay, and that's what I'm going to basically show you. So this is one of our cases in Singapore. So this is a 43-year-old gentleman whose uncorrected visual acuity is pretty good. So of course you must have good distance visual acuity if you're going to have lenticle implantation with presbyopia. But you can see actually his near vision is pretty poor. It's N36 in both eyes. He uses a plus 1.5 add, and he gets a correction of N6 with that add as well. He's right eye dominant. So remember, this is a non-dominant eye procedure. So this lenticle implantation with presbyopia is only going into one eye. So very similar indications to basically using the raindrop, if you ever use the raindrop implant, which as many of you know will now basically has been withdrawn from the market. So if you do look at the refraction, the right eye is a little bit hyperopic, plus 0.5. Left eye also basically ideally about 0.25 spherical equivalent. So the first thing to do is to prepare the donor. Okay, so I'll show you how we do this. So this is using the VisuMax. So you can see this is a donor cornea over here from the eye bag. Typically, you want to make sure that you have quite a reasonable corneal scleral rim, which they're quite used to now. You don't really care about the endothelial cell count, of course, in this situation. So normally, as long as the cornea is clear, even if the cell count is low, you can ideally basically use it for this procedure. And this is typically what we do. So we don't take tissue that would otherwise be used for transplantation procedures such as DMEC or PK. So you create the lenticle exactly the same way as you do in a patient. Dissection is exactly the same. In fact, the dissection is probably easier in this situation because it's much easier to get the lenticule. It's a lot more basically fluid. It's very easy to basically do that. We don't really alter the settings, to be frank. We use the same settings as I do on the clinical cases. So we don't really alter the settings when we're doing a donor cornea. So once you release the lenticule from the anterior side, you then basically do the posterior side, similar to what we do in patients. So that's all basically freed up. Then the lenticule is simply removed from the donor cornea. So of course you need to be careful over here. You don't want to rip the lenticule basically when you're pulling it outside the donor cornea. So this is typically a 6.5 millimeter, but you can do 6.7. It's up to you basically, whatever size you want. We normally just keep it 6.5, put in the 7.5 millimeter cap, and normally keep the depth at about 120, which is similar to what we do for most of our patients. So this is the lenticule now. So we put it onto a spear. Now I'm putting it onto a hard surface. Okay, because what I'm going to do is I'm going to hydrate it. Now the lenticule dries out really quickly because you can see this treatment is actually only a -3 treatment. So it is not that thick. So the lenticule does dehydrate really quickly. So you don't want to keep it too moist, but you do need to moisten it. So I use a wet spear just to keep it hydrated when we're going to do any sort of manipulation over here itself. And what we're going to do is I've evened out all the lenticles so it's opened up completely. Then using a trephine, I'm going to mark out the central area. So I've marked with a dot where I'm going to basically trephine around, and then I'm basically getting rid of the residual tissue from the excess area itself. So I used basically a 4 millimeter trephine to make the lenticule basically smaller. Okay, so that gets rid of the excess tissue. You do need to use a hard base because obviously using dermatological trephine. Now I'm using a 1.5 millimeter dermatological trephine to actually make my presbyopic lenticule. The reason why we do 2 trephines is that it's a little bit more accurate than just basically trying to punch one with the same way. But you can see how much tissue there is that's wasted there. You could actually, actually use 1 lenticule, but actually for much more than basically just 1 patient if once you can basically do the tracking and things like that as well. So it is possible basically to do that if you're going to do that for allogeneic usage as well. But since it's coming from a donor cornea, but you have to be careful with your tracking before you do that as well. Okay, so then we go to the patient. So we made our lenticule. Then we use a femtosecond laser to create the pocket. Now, most femtosecond lasers currently available on the market can make pockets. If you have a VisuMax, you can make a flocket, which is basically like a flap. But what you do is you extend the hinge all the way around 330 degrees, and that will make a basically little tunnel incision. So here in this example, I'm just using the Zima to make the tunnel. So what I'm doing now is looking at getting the patient to fixate on the green light. So this is on the excimer laser. I'm just trying to see where the patient is actually fixating at. This is where I'm going to put the lenticule and leave it underneath the eye. You can give pilocarpine as well to bring the pupil down if you want to help you with the centration. I'm just marking the area around the limbus. This helps with the docking situation with the Zima, so it gives you an idea basically where the symbol, where the limbus is, so then I can basically work out how long to basically make my tunnel. So once we've got an idea of the fixation, then I remember I'm going to put the lenticule underneath that dot basically, so I know basically it's well centered after we basically implant it. So the pocket is cut in the same manner as you do basically a LASIK flap or doing a pocket for basically any presbyopia. Put the suction ring on first, and then basically apply the lasers once suction ring is basically applied. So most of you will be, if you use this laser system, will be familiar with this. But as I said, all the lasers currently available on the market, they all have some sort of pocket software. So this is available from any laser system that you want to basically use, not particular to one system. So once you've done the docking, you fire the laser, and then what you'll see is that's the pocket basically created via the tunnel of the pocket. Then what we're going to do is we're going to open up the pocket. Typically, I just use my spatula that I use for smile surgery to open up the pocket as well. So that will get rid of the cavitation bubbles. So you gently basically open up the pocket. Now, you don't have to go so deep. Typically, any of you who've used the raindrop or the camera inlay would typically have gone about 150 microns or 170 microns down when you put the inlay in. So here, typically, we don't do that. Here, we only have to go 110 microns or even 120 microns because remember, this is a biological inlay, so you don't have to worry about biocompatibility, okay? So you haven't got these issues of putting biomaterials inside the cornea. So this is one of the advantages of actually using a biomaterial like a collagen scaffold that we're basically using in this situation itself. Once you've done open up the pocket with a spatula, you feed away all the cavitation bubbles. You can see that the tunnel itself leads into a pocket area normally of about 5 millimeters. You don't want to have it too big. If you have it too big, the lenticle basically may move a little bit too much inside the eye, but you can see that it's quite easy to basically get the lenticule. So lenticule, we just kept it in Optisol while I was basically doing the tunnel. Then what I'm doing is just going to wick away all the excess Optisol from around the area. And then you can see the donor lenticle at the bottom of the screen over here. And then what we're going to do is that because it's quite difficult to see because lenticles are small, if we're doing presbyopic cases, then typically we will stain the lenticule with some fluorescein. It just makes you help with the visualization. When you see the patient the next day, the fluorescein is gone, so you don't need to do it. You'll see on the next video when we do it for keratoconus that typically we don't stain because the lenticle, of course, is much bigger, so it's a lot easier to see itself. But I think for presbyopic inlays, it's basically worthwhile doing. So once you basically got the lenticule, it's stained. This is just the ordinary fluorescein strip to basically give you, if you have fluorescein fluorettes, eye drops and stuff, you can use that instead. So your staining is basically done. I'm just wicking away the excess basically fluid. Then you can just use pretty much most forceps. This is a forceps we used to use when I used to do camera inlays and raindrops. It's just a small pair of forceps to help grab basically the lenticule. I mean, it is quite small in diameter. It's only basically 3 millimeters in diameter. And only about maybe about 30 microns thick. So of course it is a little bit flimsy, but it's quite easy to grab with the forceps. Then what you need to do is you take it back to your patient. Now, if it's a left eye patient, which a lot of the non-dominant eyes are, I'm inserting this with my left hand. Okay, so it's a little bit more tricky, but I mean, what you can do is you can move the patient around to a microscope to then basically make it easier for you to insert. I'm doing this on an excimer laser, so I wanted to use the fixation of the patient to help to see where to center the lenticle itself. But if you find it difficult to do it with the left hand, you can just basically do it with a not conventional microscope as well. That will work just as well to basically do the insertion. But then you need to mark probably the center, maybe on the slit lamp beforehand, to see where the patient's basically fixating. So once you've got the lenticule, so I'm grasping it now with my left hand, and I'm going to insert this. I'm opening up the pocket. We're going to insert this basically inside the eye. So you want to try to keep it flat when you insert it, okay? Because obviously the pocket, you don't want to tear the pocket around the hinge itself. and then you gently open up the forceps. And what will happen is initially when you open up, sometimes the lenticle will want to come with you itself. So take it beyond the point you want to basically implant it, then open it up. And then using this bimanual technique, you can pin the bit of the lenticle that's already basically in the eye and then remove the forceps from the eye itself. Okay. You can adjust it a little bit if you go in, you can pull it a little bit to one side if you need to, and then you can just pin it down with the second instrument on the other side. So this is the back end actually of the lenticle dissector, and then the lenticle is basically inside the eye. Then if you want to adjust the position, actually it's quite easy. Just keep the surface wet. So you can see it's a little bit low at the moment. So what you're going to see is that we're just going to basically adjust it. I'm just going to gently nudge the lenticule basically up into position. Okay, so you can see it moves quite easy initially because the stroma is still wet. There's still fluid in the pocket, so you can adjust this from side to side. And then once I'm happy, so it's underneath the dot, but I know this is under the fixation, so I think it's okay. So we're going to leave it basically at that light there itself, and just gently tapping on. So if you don't want to tap too hard, you don't want to disrupt too much of the epithelium, but you can see how easy it is to basically judge. And what happens is, as the fluid starts to dissipate, of course, the lenticule becomes sticky and then it becomes stuck into position. And then typically we just put some antibiotics and some steroids topically to start with, and the patient will start the drops, the same as we basically do for most inlay surgery. Okay, so this is the patient basically post-operatively, so he did pretty well. So at 6 months post-op, anterior visual acuity for distance of 6'9", he's able to read N6 at 70 centimeters for intermediate vision, and N5 at basically at 40 centimeters. So he's quite happy with that. The effect that we basically got, so remember we did a -3 treatment, so he was basically getting about 2 diopter effect, because of course there will be some swelling from the tissue when we actually do the cutting itself, so that will basically thin out. You can just about see the lenticle on the OCT over here, and you can see that increase in elevation of the effect on the surface. So it's about 2.5 diopter effect that you can get on the surface. So you lose a little bit, about half a diopter from what you cut from the donor cornea itself. This is just the last video now, so I'm just showing you basically keratoconus. So the surgery is actually very similar to what I've shown you. So this is a keratoconic patient. So here we're just opening up the pocket. Typically, we make the pocket a little bit larger for keratoconus because we're implanting a whole lenticule. And you can see on the intraoperative OCT on the right-hand side, as we basically put in the lenticule inside the cornea, you just gently open this up with this spatula. So this is just a pair of forceps. So we're opening up the lenticule itself. So it's doing it quite slowly, so you can see it quite nicely on the OCT. And if there are any areas that basically haven't opened up properly, you can just use a cannula to just gently smooth out the area. So you can see the cornea, the lenticule is a little bit swollen. So again, this is from a donor cornea, as I said earlier. So it's a little bit swollen. So this will deterge quite quickly over time. Okay. So in summary, lenticle implantation technique. So as I said, you can make the pocket with any of the currently available femtosecond lasers. If you don't have one of these ones, if you have a VisuMax, it's simple. You can just make a flocket. You just need to make your hinge 300 degrees itself. We prepare the donor tissue first. Of course, most of the studies that I'm involved in, we're using donor cadaver tissue because most of our patients haven't reached the age of 40 who've undergone lenticle implantation. So eventually, obviously in the future, hopefully we'll be able to retrieve our tissue from Cordlife and then implant it back into the patient itself. Staining helps with visualization. I think this is quite important when you're doing the presbyopic lenticles because the lenticles are quite small, so it can be a little difficult to see itself. Generally, what we do is we customize the size of the implant with the pupil. So most of the time, it will be between 1 to 1.5 millimeters in diameter. If people have particularly small pupils, make the lenticle 1 millimeter. If they have slightly larger pupil, then you make it about 1.5. Otherwise, if you make it too big, it will block off the distance vision. So you need to basically, you can vary it depending on the scotopic basically pupil size itself. For hyperopic cases in keratoconics, we do a 7 millimeter lamella cut, so it's slightly bigger than basically what we normally do, so that you can get a larger area pocket because you want to increase the thickness in the peripheral area. Okay, just want to acknowledge my team in Surrey who helped develop this over the last probably decade, and thank you for your attention.
Thank you for the informative sharing, Prof. Jod. For those who just joined us, Prof. Jod is the head and senior consultant at the Cornea and External Eye Disease Department from the Singapore National Eye Centre. So he just shared what corneal lenticules are, the potential applications of corneal lenticule implantation, and the lenticule implantation technique. Please feel free to ask any question by typing in the chat box, and we'll get to them at the Q&A segment. Now that we know how useful corneal lenticules are, let's hear from our next speaker, Dr. Tang Kin Fai, on the technology behind processing and cryopreservation of the corneal lenticules. Let's welcome our next speaker, Dr. Tang, please.
Thank you, Angela. Thank you, Prof. Jod, for such an informative and definitely eye-opening presentation, no pun intended. So next, we're going to shift gear and I'll be talking about the lenticule banking, how Cordlife lab process and cryopreserve lenticules once it has been extracted from patient's eyes. So next slide, please. So first of all, I'm going to share a little bit about how Cordlife has leveraged on over 20 years of expertise of cord blood banking, cord blood and tissue banking, and cryopreservation to successfully store extracted lenticules. So a little bit about Cordlife is that now we have more than 500,000 parents that have trusted Cordlife for their cord blood and cord tissue for storage. And Cordlife has been public listed on the SGX since 2012. And we are always aiming for the highest qualities. So actually all of our labs under Cordlife have been accredited by AABB, and 2 labs are being accredited by CAP and from the US, and of course 2 labs are being accredited by FACNET-CORD overall. Next slide, please. So this is just how our market presence are. We are currently operating in 11 countries, as shown on the map. And we are operating 7 labs in 6 countries, including our HQ, Singapore, Malaysia, Indonesia, India, Philippines, and we have 2 labs in Hong Kong. Next slide, please. So our services currently can be widely divided into 2 categories. One is the banking. So currently we are storing cord blood, cord lining, tissue, and of course mesenchymal stem cells. And of course corneal lenticule, which is termed as OptiQ in our brand, is our newest banking product. And of course we also have the diagnostic branch, which have been doing testing about, say, for example, a newborn genetic screening and genetic talents test, for example. Next slide, please. So I'm going to talk about our workflow on the lenticule itself, on the collection, transportation, processing, and storage. So technically, what happens is that after the eye clinics have collected, perform operations in to extract the lenticules, then our medical courier can transport the lenticules from the clinics directly to our lab within the room temperature, which we term as 15 to 35 degrees. This is what we have validated on, and in the lab, the process of processing lenticule takes about slightly over an hour, and we actually aim to finish the cryo storage process latest by within 72 hours upon the collection. And after that, we'll just transfer that into long-term storage in a vapor phase liquefaction tank. Next slide, please. So how are corneal lenticules collected and stored? So the collection, as I mentioned before, after the SMILE procedure, we actually provide the eye clinics or hospitals with this lenticule collection kit. And next slide, please. So this is the content of the collection kit. So besides all the absorbents as well as the plastic bags, we actually have 2 tubes of sterile saline and 3 tubes for lenticule, 3 small tubes for lenticule collection. So we usually label it as left, right, and of course S as a spare. So this obviously we don't have 3 eyes. So this just in case that because the tube, the collection tube is actually quite small. So there's a chance that it may just drop and then it's non-sterile anymore. So the spare is just in case that happens. So what happens is that once the lenticule has been removed from patients, so the sterile saline can be poured into these tubes, and then the lenticules can be put inside these small containers. Then after that, it will be sent, collected by our courier, medical courier, and sent directly to our lab. Next slide, please. And of course, besides that, we also collect, we also need the data from the treatment data from, say, for example, here is actually the Visual Max report. And of course, this is actually to be recorded in our system so that during the, upon release or when it's needed, this data can be presented to the eye doctor. Next, please. Besides that, we also collect blood specimen from the patient, and usually within ±7 days of the operation. And in Singapore, we actually collect it the next day or within the next 2 days of the operation, because the procedure, the SMILE procedure, after the SMILE procedure, the patients will go back for a review 1 or 2 days later. And on the day of the operation, we try not to traumatize the patient that much. And you operate on my eyes, and then yet you take my blood. So these bloods will be used to test infectious diseases such as HIV, Hep B, Hep C, and syphilis. On the other hand, during the processing of the corneal lenticule, we actually look at the integrity of the lenticules being removed pre and post processing to look out for tears and whatnot. And minor tears are actually acceptable, as Prof. Jodhbir mentioned, that we only need the middle about 3 mm diameter of the tissue. So we'll assess that should there be a tear in the lenticule to whether it is eligible for storage or not. And secondly is that we also look at the sterility of the lenticule. So we perform testing to see if it has been contaminated with microorganisms. If it's contaminated, then we will probably have to throw that away or discard. So that technically is what we are doing. And next slide, please. So after the processing, washing, and then added with the lenticules are being soaked in the cryopreservation media, and after that we put it inside this control rate freezing profile that to go all the way from 4 degrees all the way to about -90. After that, we transfer that into our liquid nitrogen tanks to store below -150 degrees. So the actual temperature is about -186 to be exact. Next slide, please. So technically, that actually is what we are doing in our lab. And of course, we recently published a paper accepted by Tissue Engineering Part A, published together with Prof. Job's team. So the paper is still in press. It's not available yet. So that basically that's it for our process. And next slide, please. So currently, these are our eye experts that have been working with us. Of course, Prof. Jod and Prof. Donald Tan, these two are the medical advisor for advising us on the various aspects of the lenticule banking. And of course, we also have our very own Miss Jaslyn as under Eye Screen Singapore to work with us as well. So with this, I end my presentation, and I think we are open for Q&A. Thank you.
Yes, that's right. Thank you, Prof. Jod and Dr. Tang, for such an insightful session. We have quite a number of questions from our audience, so let's take this time to address as many as we can. First question is for Prof. Jod. Presbyopia will continue to progress over time. So how will we tackle the progressiveness of presbyopia after we implant the corneal lenticule?
Yeah, so that's a good question. So unfortunately, as we all get older, our requirements for near vision do go up. So typically what we will do is that I don't advise putting lenticules or presbyopic treatment with inlays in people who've just become presbyopic. So people who are using less than plus 1.5 or reading at, and we normally take that as our cutoff. The maximum you'll normally go to is about plus 3. So already these people have gone through a bit of a spurt where they drop down to plus 1.5. So that's where we know that's our starting point. So we wouldn't go, I don't advise it. If people are using 0.75 or reading at, I wouldn't advise them to basically do that. That's the first thing. The second thing is that, you know, for many patients that we see, there is a large variation. Sometimes I see people who are like in their late 30s, 38, 39, who are already using reading ads. And sometimes I see people who are like 45 who are actually not even using reading ads as well. So you do see this very large distribution in the population. So it is very specific to an individual and down to individual requirements. Now, just say, for example, like in my patient, you had that implant done at 45 years old. And of course, as that guy gets up to 50, 55 years old, what will happen is that he will still be able to see for intermediate. Okay, but what he will find is if you want to do a lot of near focusing vision, then he may have to wear reading glasses. And you have to bear in mind that we nowadays, since most of us are using digital devices, actually a lot of people want better intermediate vision as opposed to actually better near vision for focusing.
All right. Okay, the next question is for Dr. Tang. Should the clinic store the lenticules at 2 to 8 degrees Celsius before Cordlife collects the sample from the clinic?
Although it's not necessary, but there is no issues to keep it the specimens at about 2 to 8 degrees. But the thing is that for a consistent temperature profile, transport temperature from the clinics will have to be kept at 2 to 8 degrees. But we have already validated the room temperature all the way up to 35 degrees is actually acceptable for this transportation. So it's not an issue, but if you want to do it consistently.
Okay.
Thank you.
Thank you. So question 3 is for Prof. Jod. If the patient has astigmatism prior to the SMILE procedure, does the ophthalmologist need to put a mark on the corneal lenticule tissue to identify the orientation?
Okay, so it would depend on what you think the lenticule is going to basically be used for. If it's going to be used for presbyopic treatment, because we're only going to find that central 1 millimeter part of tissue, the lenticule shape in a presbyopic tissue in that central area is actually quite plano-convex. So actually we don't need to basically mark it. It only becomes an issue if you ever think that you want to implant the whole lenticule back into that individual patient. So as we did in the animals, basically, so we're actually reversing their myopia back to that original situation. So if you're going to think about doing that, for sure, definitely you need to basically mark the axis of the astigmatism itself. And I think that, like Kaifon said, that there is a form that we fill in for every single patient documenting what treatment they basically had done, what was the power, what was the lenticle parameters, what was the optical zone itself. So it's very important when we send that form off to you guys, that form is basically, or actually, to be frank, it's filled in by one of the nurses in the clinic, so I don't even have to do that. But they fill in the form and they just check to make sure it's been filled in correctly. But that form must be filled in because that information is then taken when we send it to basically Cordlife and then documented. So they have a record of exactly what the treatment was for the individual. So the answer is, it depends on what it's going to be used for. Primarily, a lot of our patients are wanting to keep it for presbyopic treatment, to be frank, not for, reversing the myopia.
Okay, well, Okay, question 4 for Dr. Tang. What happens to the lenticules after 20 years, or let's say the individual does not need a use for it within the 20 years?
Oh, after 20 years, the patient or the client, the donor, may actually choose to continue storage, and we strongly advise for that. Or they can actually donate them for clinical research. And well, eventually they can also possibly utilize them to continue enjoy good vision, since presbyopia onset is usually be around 40 years of age. So yeah, or they can donate it to their family if the family members requires it.
All right, so it doesn't require a matching, a strict matching.
No.
Okay. So the next question for Prof. Jod, is there any immunosuppressive therapy required post-operatively?
Okay, so yeah, so currently we only do implantation for autogenic patients. So basically what that means is autologous. So it's your tissue going back into your own body. So of course, because it's your own tissue, you don't need to put any long-term immunosuppression. Because of just the surgery, like people having LASIK, people having SMILE done, we do give patients antibiotic and steroids normally just for 2 weeks after the procedure. That's a routine thing we do for everybody who's having any refractive surgical procedures. Now, in the future, I mean, with our example that I showed you from what we're doing currently now, where we're using donor corneas and we put them into patients, what we do is we do give them topical steroids to basically put into the eye. But normally for the presbyopic patients, we stop the topical steroids normally after 6 to 8 weeks. They're not on anything basically in the long term. The reason why we stop it is that, remember, the size of the tissue is so small. It's only 1 millimeter of stromal tissue that we basically put inside the pocket. So the risk of actually getting any rejection episode to that is very, very, very small itself. So that's why we don't give them long-term immunosuppression itself. Going forward, of course, there are techniques as we've been working on to actually remove all the cells from the actual lenticule itself. So that's something that maybe we will do in the future as well.
All right. Okay, so next question is for Dr. Tang. What are some of the facilities at Cordlife to support the long-term storage of the lenticules?
Okay, actually, all of our Cordlife facilities operating in Singapore, Hong Kong, Indonesia, Philippines, India, and Malaysia are actually capable of providing lenticule storage. Of course, subjected to validation, because we have to validate it before we really start this service, and also the local regulatory compliance. So we have to seek the local authorities for approval. And currently, our Singapore and Hong Kong facilities are already accepting lenticules for storage, where we can actually store lenticules for not only from these countries, but also from the neighboring countries. So as far as they are being transported within time frame and within the temperature range. And I must say that Cordlife has over 20 years of experience in stem cell and tissue processing and cryopreservation. And we are really excited to extend our expertise to storing corneal lenticules. Thank you.
Okay, thank you. So Prof. Jod, the next question is for you. If the corneal lenticule is easily inserted, how does it stay in place without being dislodged over time?
Yeah, so remember when we put it in, there is a little bit of fluid there itself. So it is a little bit hydrated. That's why I was able to adjust it a little bit. And if you need to adjust it, you do need to put some fluid there. Because it's corneal tissue, what will happen is that as the tissue deterges, so as you remove the fluid from the corneal tissue, it will become sticky to the adjacent tissue itself. So it will start to stick to the adjacent area. And that's what basically keeps it in position. When we make that pocket for the presbyopic lenticules, it is slightly smaller than I showed you for the keratoconic ones. Typically, we make a 7 millimeter pocket for the keratoconics. For the presbyopic ones, I only make 5 millimeter. So we do make it slightly smaller than we do for the larger ones. But that's what basically keeps it into position.
Right. Actually, that sounds like how I remove my contact lens when it's dry.
Right, yeah.
When it's dry, it's so hard to remove.
Right. Right up, yeah, absolutely. Yeah.
Right. Okay. So the next question is also for Prof. Jod. If a patient has done LASIK or SMILE procedure previously, can the patient do lenticule implantation to correct presbyopia?
Yeah, so that's quite a good question because, of course, people have had, refractive surgery done in the past, and then they think, okay, as you got older, now can you have one of these procedures to correct lenticule? So the first thing would be is that they would probably have to have a donor cornea lenticule because it's unlikely they would have had it stored their corneas, because obviously this is a very new technology. So it's unlikely that they would have had their own cornea stored at the time when they certainly wouldn't be available for LASIK, but certainly at the time they would have had SMILE done. So that's the first thing. So it'd have to be a donor cornea. The second thing is that initially all these kind of studies would need to probably be done in some sort of trial. So I can tell you that from the experience that we have with the raindrop underneath LASIK flap, it did work exactly very similarly to basically putting a raindrop, which is another space occupying material implant in a normal eye that hasn't had any surgery itself. But so the answer would be probably yes, but I would say to you that we need to do studies to basically show that it's just as efficacious as doing it in a primary eye. Most people at the moment that would be having this done, or most people that we pick, haven't had any refractive surgery done. So they people who are naturally see well for distance, like I showed in that example, and they just don't want to wear glasses basically for reading. So those are the patients that we've basically been doing currently now.
Right. All right. So thank you, Prof. Jod and Dr. Tang for the answers. And thank you to the audience for all your questions. It's almost 7 and I'm sure it's dinner time for many of you. So once again, we thank you for spending your precious evening with us. We hope you have gathered new knowledge about this revolutionary technology in the ophthalmology field. Cordlife Group Limited is the industry expert in stem cell banking and is the first in Asia to launch lenticule banking service, which is branded as OptiQ. The technology behind OptiQ was invented by Professors Jodhbir Mehta and Donald Tan of Singapore Eye Research Institute, patented by SingHealth, and Cordlife is the exclusive license holder of this patent. OptiQ's medical advisors include Prof. Jodhbir Mehta, Professor Donald Tan, and Senior Optometrist Ms. Jasmine To. If you are keen to collaborate with us on introducing lenticule banking to your patients, please drop us an email at optiq@cordlife.com as shown on the slide. Our friendly staff will get in touch with you soon. We have come to the end of the webinar. We hope to see all of you around for the next webinar. Have a good evening ahead. Thank you, Prof. Jod. Thank you, Dr. Tang.